Welcome everybody to the 2022 Orthopedic Physical Therapy Residency Research Day. So this is when our January residents present their research findings. And this year we have one traditional research study, observational study, and two case reports. So we have Dr. Kyle Bradley presenting an observational study looking at the impact of post-professional training on outcomes, patient outcomes. Then we have Dr. Lindsay Brantigson presenting a case report, and then we follow up with Dr. Pat Russell presenting another case report. So without further ado, I will turn it over to Dr. Kyle Bradley.
Thank you, Dr. Caraha. So like I said, our title of my project is Training Matters, Analyzing the Effectiveness of Postgraduate Training on Patient-Reported Outcomes. I have no disclosures to discuss. So physical therapy has developed from a Bachelor of Science to its current level as a Doctor of Physical Therapy to encompass the amount and depth of knowledge needed in the field. Patient expectations have grown in a similar manner, expecting expert-level care from these providers throughout the healthcare industry. However, DPT school prepares the entry-level physical therapist to be a generalist, leaving a gap in between the PT's knowledge base and the patient's expectations. Prior to 1999, there wasn't a structured way to advance from a generalist to a specialist, and PTs relies on factors such as the natural progression with time. Trial and error to determine what did and didn't work for their patients, or taking continuing education courses until their skills improved to meet these expectations. In 1999, this changed with the first accredited residency program established at Kaiser Permanente Medical Center in Los Angeles, California. The residency provided a way for PTs to bridge the gap between generalists and experts. However, little research has been done to study the effectiveness of these residency programs. Previous research conducted in this area did not take into account years of experience and the growth that can occur with this through trial and error. Our hypothesis is that completing an orthopedic physical therapy residency program leads to better patient outcomes when compared to peers at a similar level of experience. This study received approval by the St. Luke's Hospital IRB. It is an observational retrospective study utilizing patient outcomes data gathered from photo. Subjects were classified into one of four mutually exclusive categories based upon their highest earned certification. Inclusion criteria is licensed PTs employed in the St. Luke's network with at least 1 year of data and photo, and exclusion were PTs whose primary patient population was not orthopedic, or if the clinician had less than 40 patient episodes in photo. For our procedures, we pulled outcomes data from photo for a 12-month period ending June 2022. We collected demographic information for the sample and then compiled this in REDCap. Our statistical analysis was separated in two different dimensions. First, we assessed and compared the demographic information for our included samples, with the results going to be on the next slide. Next, we performed a separate ANCOVA for our three measures, which are effectiveness, utilization, and satisfaction. A post-hoc comparison using Fisher's least significant difference was used to compare the difference between our samples in relation to the outcomes. Our covariate for our analysis was years of experience, and as stated before, this is how our study has differed from previous attempts to research this topic. Our alpha value was set at 0.05 for statistical significance. For demographics, we assessed the number of samples in each group, the average years of experience for these groups, and the standard deviation within the group. Due to the small sample size of fellowship-trained PTs, further analysis with a larger sample size is necessary to analyze the differences between these groups. However, as highlighted in the table, the resident sample has a much lower average years of experience compared to our other three groups. And we also performed an analysis of variance for years of experience, and we did find this statistically significant difference for years of experience. So effectiveness is the amount of change from the initial photo intake survey to the last one completed by the patient, with a higher number denoting a higher level of overall function. In terms of effectiveness, there is a trend towards better patient outcomes with higher levels of training. However, the residency trained group was the only group to have both a statistically significant and meaningful difference when compared to those without any postgraduate training. Utilization is the change in effectiveness score in a certain period. So for each intake survey, there's an expected length of PT treatment, which is calculated from the average length of time for that given condition for all encounters in photo. A higher score for utilization would mean better effectiveness in a shorter amount of time, meaning that the clinician is exceeding the expected results in a more efficient manner. For utilization, both the residency trained and non-residency trained orthopedic specialist groups had statistically significant and meaningful improvements compared to the group without any training, and the residency trained group did display slightly better outcomes for utilization compared to the orthopedic specialists. Lastly, satisfaction is measured through 9 set questions performed after each follow-up survey, ranging from very satisfied to very dissatisfied. Satisfaction was found to be about equally better with all 3 groups that achieved advanced training or certification compared to the group without any training. And again, both the residency trained and non-residency orthopedic specialist group were found to be statistically significant. But again, due to the small sample size of the fellowship trained group, a statistically significant difference was not determined. So in our discussion, little research has been undertaken to assess the effectiveness of an orthopedic physical therapy residency program. Previous research did not control for years of experience as a factor that could affect patient outcomes. Our data shows a significant improvement in effectiveness, utilization, and satisfaction when completing an orthopedic residency program when they are compared to peers at a similar level of years of experience without any training. And despite having fewer years of experience compared to the other 3 groups in the study, the residency trained group demonstrated better patient outcomes in all 3 domains, and they were all statistically significant. For clinical relevance, so for clinicians that want to improve, completing a residency program leads to improved patient outcomes in a much shorter period of time. Our research indicates that completing a residency advanced a clinician almost 7 years compared to their counterparts. This will allow a clinician to meet the patient's expectations of improved outcomes that is expected of an expert in their field. And improved patient outcomes and satisfaction achieved through a residency program make hiring a residency trained PT the more attractive option for a hiring manager. Next, onto our strengths and limitations. So where previous research in this topic did not control for years of experience and the natural progression that can occur with this, ours did. This allowed us to analyze the effects of these programs and compare it to like subjects. While there are some limitations with photo, it is currently the best outcomes measure tool we have. It is risk adjusted and is based off of item response theory. Our limitations for this study, again, include a small sample size of fellowship trained PTs. The outcomes are not patient specific, and the majority of the residency trained individuals in the study came from 1 residency program. So continued research into this area will be beneficial to quantify the improvement a physical therapist undergoes by completing a residency program. To make our analysis more complete, we will be conducting a case-controlled analysis to determine the specific improvements that can be expected by completing a residency program versus those expected with time and practice. So in conclusion, there is a statistically significant and meaningful difference related to patient-reported outcomes when a physical therapist completes an advanced level of training or certification. Residency-trained physical therapists demonstrate improved patient-reported outcomes when compared to peers without advanced training or specialization, progressing at a much more efficient rate as well. And here are the references for this project. And we'd like to acknowledge Dr. Jill Stoltzfus for assisting the data analysis and Dr. Rhett Holmes for data collection through photo. And lastly, any questions?
Please feel free to either unmute yourself or type into the chat any questions you might have. I do have a question, just to clarify, with the fellowship, you mentioned that it is a very small sample size.
Yes.
It looked like the fellowship outcomes were about the same as, or slightly better, depending on which domain you were looking at, than residency and board certification. So do you feel that's a clinically relevant trend, or do you think that that might just be, why wasn't it statistically significant?
Well, having a small sample size, didn't allow us to accurately compare those different groups. But we also saw the big difference that we saw in our study was that we controlled for years of experience, and that the residents had a much lower average year of experience, about 4.8, compared to fellows who were around 12 years of experience. So this could just be due to the fact that they're closer out of school, more recently studied, or the fellows have just kind of spaced out their training over the years, which could lead to some variance there. But I think having a bigger sample size of fellows will allow for more accurate analysis of that. And I would expect to see a trend, as we did with everything else, to get even better with the fellowship trained.
Okay, so a larger sample size you would expect
Yes.
to show a statistically significant difference.
Yeah, because we did find for most of them, for 2 out of 3 at least, they were a little bit better than the residency trained therapist. But again, if it's not significant data, it's tough to say this is a true comparison.
What other questions do you guys have? Okay. Well, we'll have time at the way end to ask any further questions if you do have them.
Up next is Dr. Lindsay Brannigan for a case study.
All right, good afternoon, everyone, and thank you for tuning in. I'm going to be presenting on my imaging case study. The title is Pediatric Hip Pain as a Result of a Unicameral Bone Cyst, an Imaging Case. I have no disclosures to discuss, so we'll start with a little bit of background. Physical therapists are now treating many patients via direct access, making them first contact providers. This means that differential diagnosis is becoming crucial, and the ability to recognize inconsistent findings and refer for imaging when necessary is very important. The American College of Radiology guidelines should be used to aid in clinical decision-making by all physical therapists. I'm now going to provide you with a little bit of background on a couple common pediatric hip pathologies, which will become relevant to the case in a few minutes. So common pediatric hip pathology should be considered for children presenting with hip pain. First, we want to look at slipped capital femoral epiphysis, or SCFE. This is the most common hip disorder affecting adolescents between ages 8 and 15 years old. We also have leg calf Perthes disease, and we typically see this presentation between the ages of 4 and 8. Additionally, bone cysts. Unicameral bone cysts typically occur in children between the ages of 4 and 10 years old. Going to focus a little bit more in on that unicameral bone cyst. The incidence is greatest around 9 years of age, and these can typically go unnoticed unless they're discovered coincidentally or following a pathologic fracture. They're found with MRI and typically located in the metaphyseal regions of long bones, and they're often pretty difficult to diagnose because they're painless and most only experience symptoms once this develops into a fracture secondary to the cyst. Surgical intervention is necessary to decrease the risk of fracture when one of these cysts is discovered. So the purpose of my imaging case was to demonstrate the use of ACR guidelines by a physical therapist to appropriately refer a patient with inconsistent findings for imaging prior to beginning PT treatment. A little bit of history. The patient in the case was an 11-year-old female. She was referred to physical therapy by her primary care provider with a diagnosis of iliotibial band syndrome. Her past medical history was unremarkable, and she had no pertinent family history either. So 1 month prior to PT evaluation, she began experiencing just some generalized right hip pain. And 1 week prior to PT eval, she contacted a soccer ball, and this significantly increased that hip pain that had began about a month ago. She described the pain as sharp and rated it as 6 out of 10. And aggravating factors included running, kicking, and stairs. She had a BMI of 18.27 and she had not yet had her first menstrual cycle. So looking at her physical exam, she had deficits in right hip flexion and internal rotation range of motion. Her hip flexion measurements were 100 degrees on the right and 125 on the left. Hip internal rotation measured 30 degrees on the right and 45 on the left. Additionally, she had weakness in right hip abduction and external rotation measurements. Her abduction manual muscle test was 3 out of 5 on the right and 5 out of 5 on the left. And external rotation manual muscle test was 3 out of 5 on the right and 5 out of 5 on the left. She had a negative Scour test, negative Ober test, and positive Thomas test. And she also did display a Trendelenburg gait pattern. So the clinical impression, based off her history and physical exam, they were consistent with musculoskeletal hip pain. However, a SCFE could not be ruled out, and this is due to her hip flexion and internal rotation hypomobility, her age, and her antalgic gait pattern. So the physical therapist decided to use the ACR guidelines, and he recommended a radiograph before beginning treatment. Based on these guidelines, he used the ACR guidelines for acute hip pain with suspected bony pathology or fracture. Radiographs were ordered by the patient's PCP, which did reveal a large lesion at the proximal femur. Let's see if I can get these for you. Right there in that one. And right there in that right radiograph. So after this, the radiologist then recommended some magnetic resonance imaging, which revealed a lesion compatible with a cystic bone lesion. The ACR criteria to support this was suspected fracture variant 2, next imaging study. And we see that right here. There in the left image. After this, a CT scan was ordered to rule out a fracture. The CT scan came back and revealed a cystic lesion consistent with a unicameral bone cyst, as well as a pathologic fracture. And the ACR criteria to support this was suspected fracture variant 2, next imaging study. So the outcome, the patient received surgical intervention less than 3 weeks after she presented for her initial PT evaluation. She underwent curettage and grafting of the right proximal femoral bone cyst with intermedullary nailing. She was able to return to PT 1 month following surgery for post-operative rehab, and she was able to attain her prior level of function, including soccer, approximately 12 weeks post-operatively. So the main takeaway points are that timely and accurate clinical decision-making is essential, especially in the direct access scenario, which is becoming increasingly popular. And ACR guidelines must be used by PTs to help determine the need for imaging or referral. Common pediatric hip pathology should be considered for children with hip pain, and the ACR guidelines recommend a radiograph as the appropriate initial imaging for acute hip pain with suspected bony pathology. An MRI and CT scan are used to further clarify and aid in surgical decision-making for bone fracture and tumor. I would like to acknowledge the other physical therapists who were a part of this research study. Thank you to Dr. Stitt, Dr. Karaha, and Dr. Fisher. And does anybody have any questions?
Again, please feel free to either unmute yourself to ask or type into the chat. All right, I do have a question. Having gone through this, I know this one of the other co-authors was the one who saw this patient initially. Is there anything in hindsight that you guys would have done differently to either expedite these results or help this patient any differently than you did now that you have completed this and found all of this information.
Yeah, I mean, I obviously can't speak for the treating therapist,
Of course.
but I know Pennsylvania is silent on whether physical therapists are allowed to order imaging or not. So in this case, I know the treating therapist did have a good rapport with the patient's PCP, so he was able to directly go over and talk to him, and it was able to happen pretty quickly. But you know, if that weren't the case, he could have tried to order that imaging himself if there was any sort of delay in that instance. But the fact that she was able to, you know, receive the surgery within 3 weeks of being seen is pretty amazing. So
Pretty cool.
Yeah.
Thank you. Any other questions? Okay, thank
And
you.
Here are my references. And next I will introduce Dr. Russell, who will be presenting on his case study.
Right. Thank you, everybody, for attending today. So today I'm going to be doing a case report describing the management of a 16-year-old male after ORIF of an ischial tuberosity avulsion fracture. I have no disclosures here to discuss. And a little bit of background on these injuries. So adolescent sports injuries currently are on the rise. And in those, only 3 to 5% of those constitute pelvic fractures, showing that they're quite rare. And apophyseal fractures are more common in young athletes due to the non-ossified growth plates. And in that case, 68.5% of adolescent pelvic avulsions are in males. And of those, around 14 to 29% are IT fractures, ischial tuberosity fractures. And as far as return to sport rates go, in a review done in 2022 and 2017, they found that in all apophyseal injuries, there is a return to pre-injury level of about 80 to 83%. That number is higher, 92, 95 with surgical interventions, and a bit lower, 79 to 80% with conservative. Now looking a little bit more specifically at ischial tuberosity injuries, from a history standpoint, they most commonly occur during sporting activities that require rapid movements, cutting, jumping. Mechanism of injuries typically occur with forceful knee flexion contraction with the hip flexed, creating a very strong eccentric contraction leading to that avulsion. And commonly there will be a sudden pop with an immediate onset of pain after that injury. From a physical exam standpoint, there's going to be localized tenderness to the ischial tuberosity, some degree of limited range of motion, and commonly there's going to be swelling, both at the ischial tuberosity and down the posterior leg. And as far as diagnosing these goes, these can be commonly determined with an X-ray, and then after which they will typically do an MRI and CT to better visualize the fracture displacement. And you can see here, let's see if I can get the pointer to work. Go. If you look over here, you can see this is an initial injury here, the fragment piece. And again, this is the same individual being checked out at different stages. Again, you can still visualize the fracture. And then again here, you can see it again. And surgery is indicated commonly when there's greater than 1.5 centimeters of displacement or after failure with conservative treatment. And similar to what I discussed earlier, return to sport rates following surgery with ischial tuberosity injuries, again, there's around a 91% return to sport rate and about a 63.6 achieved full or nearly full level. There currently is no data regarding return to sport for conservative treatment of these injuries, and that likely is due to the rarity of the injury. And again, currently no return to play, return to sport protocols as well. So the purpose for today is to describe the management of a patient after ORIF of initial tuberosity fracture with the goal of return to sport. This is the case description here. 16-year-old male athlete, played multiple sports. This individual, the injury occurred while he was playing football. This individual had no relevant medical history, and the mechanism of injury for him was similar to what's described in the research. Landed onto an extended knee, flexed hip and trunk, and felt that immediate pop. Athletic training immediately referred him to get imaging, which revealed an inferolateral avulsion of the ischial tuberosity of around 1.5 centimeters. The individual then underwent ischial tuberosity ORIF. And you can see here in the picture, here is the fracture, and below here is the CT scan, where again, you can see that very well visualized. And the CT was how they really determined the actual displacement. This individual presented to PT about 4 weeks out from surgery. Surgical precautions wise, he was supposed to be non-weight bearing weeks 1 through 4, partial weight bearing weeks 4 through 6, and full weight bearing by 6 weeks. The goal of this was to allow adequate healing of the tissues in that first 4 weeks, and then slowly start initiating some motion with the goal that by 6 weeks, everything should be healed. And the goal is to start loading up the bone as well as restore his weight bearing. From a concern wise, after the surgery, the key here, we needed to allow for healing of the bone, which, as you can see with the weight bearing, and that first 4 weeks, that's where the majority of that's going to be occurring. So by that 4-6 week window, we can start to introduce that. Goals here again: prevent knee stiffness, muscle atrophy of the surrounding joints, and restore any strength deficits that he's going to have. From the physical exam standpoint, he presented with non-weight bearing with use of crutches. Pain levels were pretty well controlled, 0 current. And at the worst was around 1. Incisions all healed well, no drainage, anything along those lines. Strength-wise, we deferred any testing just due to precautions, avoiding stressing the tissues. However, he was able to demonstrate a quad set in his brace. Range of motion, seeing as he was again locked in the brace, could only really achieve 90 to 110 degrees of flexion. And hip, 5 to 90. Avoiding that deeper than 90 degrees of hip flexion to avoid overly stressing the ORIF. Clinical impression here, we're concerned about him losing passive range of motion as well as losing his quality of motion. Ideally, this is something that we want to restore immediately, but again, we want to be careful about overstressing these tissues in that time frame we had. Now, as he presented around week 4, there wasn't really any concern to start at least moving the joint. So that was initiated as soon as he first treatment session. Next piece here, looking at strength and neuromuscular function. We did not assess the actual strength, due to precautions. However, research shows that with just short terms of immobilization, you're going to see strength deficits, around 2% per day. Muscle size will decrease around 0.4% per day. Force development decreases 0.7% per day, and MVICs will decrease around 1.1% a day. Now, these are something that we want to restore, but again, the key here is not to overstress this individual's healing. So, at that 4-week window, this is something we could start to gently reintroduce, which didn't really come later until around week 6, but this is something we're keeping in the back of our mind. And from a proprioception standpoint, as this individual did want to get back to playing higher level sports, research has shown with as little as 12 hours of immobilization, there's going to be reduced corticospinal excitability, decreased synaptic strength, and decreased motor performance. Again, none of these things that we could assess at this point, but we know that these things are going to be occurring, as with just 12 hours of mobilization, this individual is in basically ultimately going to end up being about 6 weeks of mobilization. Interventions wise, phase 1, the first 4 weeks here, essentially initiated all kinds of range of motion and some very gentle active range of motion, all in prone positions to avoid, again, deeper knee flexion at this time. The individual, his brace was locked at 90 degrees for the first 2 weeks, unlocked to 60 the second week and the 4th week, and then the goal, he was locked to 30 weeks 4 and 6. And here, keeping in mind our strength deficits, some gentle isometrics of the quad and hamstring were utilized. Phase 2, 4 to 6. Here, we're trying to progress him from his weight bearing from non-weight bearing to partial, with the goal of getting him full weight bearing tolerated by week 6. Again, here, progressing hip and knee range of motion, active range of motion, and gently progressing all the quad and hamstring isometrics. Phase 3, at this point, any sort of concerns of re-injuring or disrupting any of the healing at this point are gone. So, we initiated open chain, closed chain, hamstring, quad exercises, starting double leg, progressing to single, initiating open and closed chain, hip and core strengthening, nerve light techniques, neuromuscular re-ed, double and single leg balance and stability activities, building off of proprioceptive deficits he likely has at this time. And the goal was to get him to return running around the 3-month based on testing. And this came from previous research on ACLs. Weeks 12 through 16, the final phase here, essentially progressed all the previous activities that we described. And then around that 12-week window, initiated plyometrics, progressing double leg to single leg, and then again, initiating agility and sport-specific activities as his goal was to get back to basketball. And here are the results coming up. At around the 4-month time, he had full range of motion, active, passive, hip, knee. Force-wise, this was done with isokinetic testing, demonstrated a quad ratio of 118%, a hamstring ratio of 99%, and a hamstring to quad ratio of 44%. Again, there's no specific criteria for returning these individuals with ischial tuberosity injuries, but going off of research on ACLs, we felt it was adequate to start returning him to both sport and the more sporting activities. Pain levels were 0 at that time, and from a functional standpoint, his initial evaluation assessed by photo was 43 and by discharge was 91. This individual by 4 months was able to return to sport based on healing timelines, physical testing, and without any complications. Now, the only thing that, as far as research goes, we do not understand what re-injury rates are after surgery, as well as what long-term outcomes look like after those. And again, trying to describe what optimal timing would be for these individuals for return to sport. However, this case report shows that we were able to kind of find a pretty good timing there. And finally, facilitating the return to sport, keys you're going to need is going to be understanding the surgical procedure, understanding their tissue healing timelines, and adequately stressing tissues with graded interventions. And here I'd like to acknowledge all these individuals for helping me along the way with this case report. Here are my references and what questions do you guys have?
Patrick.
Mhm.
Great job. It seems like this patient would progress well. You had mentioned that a referral or they would consider surgery if the fracture displacement was 1.5 centimeters or if they failed with PT. What would be the criteria for failing with PT? Is there a timeline that you're looking at? Like, not better?
They didn't specify a timeline. It was more of if they weren't able to return to whatever their goals were. In this individual's case, if you return to sport, chronic pain, inability to restore full motion, things like that. Like I said, most of these people are young, so most of their goals are higher level activities. So usually the failing the conservative treatment is they don't get back to doing those activities, and that's where then they come in with the surgical procedures.
Great presentation. A lot of the timelines were based off of healing times, which I think is fantastic. Is there any, and this individual appeared to progress very, very well. To generalize this to other patients, would you look at specific physical performance criterion in addition to time-based protocol for other patients? Like if they didn't hit a certain strength level or range of motion by the end of each time?
Yeah. So he by that 12 to 16 week window did meet all of the kind of expectations that we were looking for as far as returning to sport. If he didn't, we know it takes roughly 6 to 8 weeks to kind of sort of either gain, strength back and stability. So, if he wasn't hitting those windows, at that time, we'd be more likely to recommend another month and a half of PT, reassess. Ultimately, if he's not hitting those criteria, he's likely going to have a higher risk of re-injuring himself, as far as return to sport goes.
Awesome.